Hello and welcome to my channel. This is my first video on a new course that I'm starting called the MBBS FlashDash, which is mainly aimed at final year medical students who need a quick revision before their finals. I will be starting on cardiovascular, and in this video, it will be on part 1 of the cardiovascular series. Do check out the links below in the description if you want written notes from my website and also flashcards, which I've uploaded on Pinterest. So let's get started. In this video, we will be covering acute coronary syndrome, complications of myocardial infarction, pulmonary embolism, and cardiac tamponade. First one, acute coronary syndrome. So acute coronary syndrome can be divided into ST elevation myocardial infarction, non-ST elevation myocardial infarction, and also unstable angina. So if somebody asks you what is acute coronary syndrome, it's an umbrella term for these three. So now how do you differentiate between these three? First of all, you need to do an ECG, and it's from the ECG, then you can differentiate if it's ST elevation or a non-ST elevation. But the thing is, in unstable angina and non-ST elevation, they are both ST depressed, or they can even appear normal. So for that, you need to check the cardiac enzymes. So a little bit about each of these three. For ST elevation myocardial infarction, the thrombus completely occludes the vessel. So basically, there's a complete blockage over there. And if you do an ECG, of course, as the name says, ST-EMI, there are ST elevations on the ECG, or sometimes you will find that there's new left bundle branch block. So new left bundle branch block is usually indicative of a new myocardial infarction, typically inferior myocardial infarction. And of course, if you check the cardiac enzymes, it's elevated. So this is how a normal ECG look like. Use this as your reference. In a STEMI, there is elevation of the ST segment. So this is the ST segment, and this is elevated. Now moving on to non-ST elevation myocardial infarction. There is a blockage, but it's not completely full. But the thing is that it's sufficient enough to cause tissue damage and mild myocardial necrosis. So there is occlusion, but it's not full. And when you see in the ECG, there is ST depression. So you see here the ST segment. Over here, it's depressed. It goes a bit lower. Sometimes you may even have T-wave inversion like this. But then when you do the cardiac enzymes, it's elevated. Basically, if there is elevation in the cardiac enzymes, in the case of acute coronary syndrome, it's indicative of a myocardial infarction. So for unstable angina occurs even at rest, as opposed to stable angina, where chest pain only occurs when there is with activity or with physical exertion. Unstable angina occurs even at rest. So it's non-occlusive thrombus. Basically, there's no blockage yet. And when you do an ECG, there may be an ST depression, like in non-STEMI, or a T-wave inversion. So it's very similar presentation on the ECG. But when you check the cardiac enzymes, it's normal. It's not elevated. Okay, so here are some clinical features. Obviously, they'll come with a chest pain. So the chest pain can be central or left-sided, substernal, or even epigastric. So the thing is that it's not common to have an epigastric pain, but some may present with epigastric pain. And the thing is that with this pain, it may radiate to the jaw or the left arm or the shoulder. And this is actually due to the presentation of the dermatomes. And when it comes to the chest pain, it's often heavy and constricting. It feels like an elephant is sitting on their chest, or they may even feel like they're doomed. So there are a few other associated clinical features: dyspnea, sweating, nausea and vomiting, and they may even appear pale and clammy. Some risk factors to take note of, and it's very important to remember this because you can even apply it basically in anything that has regards to the cardiovascular system. So for the risk factors, you need to remember there's the non-modifiable and also the modifiable. When it comes to the non-modifiable, it occurs with increasing age, the male gender, and family history of any acute coronary syndrome or cardiovascular events. And this is important when you're taking a history of the patient. Also, when it comes to the male gender, it's not that it does not occur with female, but it's important to note whether they're menopause or not, because it's more common in women who have menopause. So a few modifiable risk factors: smoking, diabetes mellitus, and patient with uncontrolled diabetes, they usually present with a silent MI, meaning that they suffer myocardial infarction without presenting any clinical features. The classic chest pain, it's not present in that case. Hypertension, hypercholesterolemia, obesity, poor diet, alcohol consumption, poor sleep, and also stress. So how do you go about the investigation? So first of all, if a patient comes in with ischemic chest pain, basically you suspect that this patient may be having a myocardial infarction or even an unstable angina. You're just not sure. First of all, you need to perform an ECG. And from the ECG, you will take note of the ST segment. Is it elevated or is it not elevated? And remember, for non-STEMI and unstable angina, they have the same presentation. So if it's elevated, granted it's a STEMI, it's an ST elevation myocardial infarction or ST elevated myocardial infarction. However, if the ST segment is not elevated, then you need to proceed with checking the cardiac enzymes, particularly the troponin T. Now, if the troponin is elevated, it's a non-STEMI, it's a non-ST elevated myocardial infarction. However, if the troponin is not elevated, then you can classify this as an unstable angina. Basically, if the cardiac enzymes is elevated, it's definitely a myocardial infarction, because even with STEMI, when you check the cardiac enzymes, it is elevated. However, this is the stepwise that you should go about. You do not jump straight away to the cardiac enzymes. You first perform an ECG, determine the ST segment, is it elevated or not elevated. If it's not elevated, proceed with the cardiac enzymes. Elevated, it's a myocardial infarction. A non-STEMI, not elevated, it's unstable angina. So there are other investigations that you can perform. Take note that even in the next slides, I will put first line, next best investigations. Even when it comes to diagnosis, the best diagnostic investigation, let's say, because this is important when it comes for your MCQs. And for your MCQs, they will basically write a long story. I'm sure you know, because you've practiced like in the books or even in your exams. So at the end, they will just ask like, so what's the first line investigation you would do in this case, or what's the next best investigation you would do, or which investigation would you do to confirm this diagnosis, so on and so forth. So the first line investigation, of course, is to do an ECG. As I mentioned earlier, you need to determine the ST segment, is it elevated or not. And the next best investigation is to check the cardiac enzymes. If it's a myocardial infarction, it's elevated. The rest is basically regular investigations that you would do. So full blood count to check for anemia. It's not indicative of an acute coronary syndrome. Basically, you just do it when the patient is admitted. What are the routine blood works you would do? You check the HbA1c or the fasting blood glucose to check for diabetes or elevated blood sugar, because some of them, if they are diagnosed with diabetes, maybe it's uncontrolled. And if they are not diagnosed with diabetes, they never know actually that they have diabetes. So you'll find that the blood sugar is elevated. You do a urea and electrolyte, liver function test. Basically, it's before prescribing a drug like ACE inhibitors and statins. Chest x-ray to rule out other cardiac causes. Echocardiogram to assess the functional damage. Because echocardiogram, it's basically echo of the heart. You can see the heart structures when you do an echocardiogram. Sorry, it's like an ultrasound of the heart. So you can see which part is actually damaged, which may occur with myocardial infarction. And a CT angiogram to see the degree of occlusion in coronary artery disease. So in any cardiovascular investigation, in regards to the heart, chest x-ray, ECG, echocardiogram comes together as a package. Even when you're unsure and you know it's a cardiac case and you're just not sure, I mean, like, not in the case of acute coronary syndrome, I mean, can be even be heart failure. You can just straight away say, I want to do a chest x-ray, ECG, and echocardiogram. So sites of myocardial infarction, this is on the ECG. So over here you can see there are some colored spots which indicate the areas of the heart that is affected. For the inferior MI, the leads affected would be leads 2, 3, and AVF, and usually it's the right coronary artery that's occluded. For lateral myocardial infarction, leads 1, AVL, V5, and V6, it's the left circumflex artery. Anterior, or sometimes they will say anteroseptal, it's V1 to V4, and it's the left anterior descending artery. And anterolateral, it's leads 1, AVL, V4, V5, V6. And it could be the left anterior descending artery or the left circumflex artery. Now, if you have trouble remembering the leads placement on the ECG, or if you have a photographic memory, then you can just remember this. Because for me, I get really confused with remembering the area and the leads associated with it. So for me, it's just easier to remember when I see an ECG, okay, this part here, it's the inferior part that's affected. Over here, it's anteroseptal. Over here, it's, lateral, like that. Management. Okay. The management is different for ST elevation MI and non-ST MI, and also unstable angina. So in the case of an ST elevation MI, in the acute setting, basically when a patient comes in to the hospital and then they are having myocardial infarction after you've done the necessary tests. So the mnemonic to remember here, it's MONA plus low molecular weight heparin, or basically just MONA plus heparin. So M is for morphine, you give it through IV. O for oxygen, N for nitrate, sublingual glyceryl trinitrate, and also aspirin. Now, after you've managed them, they've been stabilized and you're going to discharge. So for the chronic long-term management, what would you prescribe? The mnemonic to remember here is AABC plus S. So A for aspirin, lifetime. ACE inhibitors, lifetime. Beta blockers for 12 months. Clopidogrel for 12 months. You can even give ticagrelor. And also statins, lifetime. So this is important if you have a short essay questions or modified essay questions. Now, in the case where you're having MCQs, now they would ask, what is the gold standard? They give you a scenario, sometimes even throw in the diagnosis, like this patient is having an ST elevated MI, so on like that. What's the gold standard treatment? So gold standard would be a PCI. PCI is a primary percutaneous coronary intervention. And it's important, sometimes they will mention the duration. If the patient presents within 12 hours of onset of symptoms, then you do a PCI. However, if it's longer, or maybe PCI is not available or not in your list of options, then you would choose thrombolysis, and it could be either alteplase or streptokinase, and usually alteplase is preferred over streptokinase. So that's for STEMI. Now let's go to non-STEMI and unstable angina. So in this case, should the patient be suspected of a non-STEMI or unstable angina, or maybe they've even included in the STEM that the ECG shows a non-STEMI, and also they did the cardiac enzymes, it's elevated or maybe not elevated. So what would you do? What is the first line treatment, let's say? So what you would give immediately would be aspirin 300 milligram and low molecular weight heparin. But the full management, the full treatment is over here. So the mnemonic for that is Batman. And this, maybe if they ask in your short essay question or your modified essay questions. So B for beta blockers, A for aspirin, T for ticagrelor or clopidogrel, M for morphine, A for anticoagulant, so you would give fondaparinol, and for nitrates, and also oxygen if the oxygen is less than 95%. So you would always try to aim for higher than that. All right, so that's for acute coronary syndrome. Let's go to the next one. Complications of myocardial infarction. So the mnemonic to remember here would be DREAD, and this is asked a lot. What are the complications of myocardial infarction? So D for death, obviously. Sometimes the patient would present death on arrival. R for rupture of heart septums or papillary muscles. E for edema, which is seen in heart failure. A for arrhythmia and aneurysm. D for Dressler syndrome or pericarditis. So if you have trouble remembering the other stuffs, you can just remember DREAD mnemonic. That's basically what I remembered in medical school. Just keep it at the tip of your fingertips. So if that, the most common cause of death following a myocardial infarction is due to ventricular fibrillation. Just remember that, ventricular fibrillation. If the patient suffers a rupture of the heart septums or even the papillary muscle, they may get a ventricular septal defect or acute mitral regurgitation. They may even suffer heart failure. So they will present with edema, arrhythmia and aneurysm. Arrhythmia, basically irregularity in the heart rhythm. So the patient may have ventricular fibrillation or ventricular tachycardia. So if the patient presents with ventricular fibrillation, you need to do a defibrillation. If ventricular tachycardia, then you can opt for amiodarone, the carotid massage, and finally a DC cardioversion. And they may also get left ventricular aneurysm, and this is due to the ischemic damage, which causes the muscle layer of the heart to become thin and then forms an aneurysm. Dressler syndrome or pericarditis. So it depends on the duration. They have very similar presentation actually. I mean, if you look at Dressler syndrome and pericarditis on the ECG, they're just the same. Even when they present to you, it's the same. So if it's 48 hours following a myocardial infarction, then it's acute pericarditis. If it's 2 to 6 weeks following myocardial infarction, then it's Dressler syndrome. So obviously, all of this occurs at different timeline. But what's important to know for your exam is the complications of myocardial infarction, and this is all of it. And they can ask this maybe in MCQs. If it's in MCQs, then you're lucky. I mean, it's really simple actually. Or they may amp it up a bit by giving the duration and maybe the clinical feature. The clinical features, maybe throw in some investigations and ask, what is this patient suffering from, let's say, or maybe during your long case examination, or maybe the lecturer just asks, like, what are the causes or complications, what are the complications of myocardial infarction, so you can just impress them with this. Okay, so a little bit of explanation about each of it. I won't go through all of it. So for ventricular septal defect, it usually occurs the first week after a myocardial infarction. And it's due to the rupture of the interventricular septum, the septum that divides the right and left side of the heart. And if you were to auscultate, you would hear a pansystolic murmur. And the way to diagnose this would be through an echocardiogram. For acute mitral regurgitation, it's due to ischemia or rupture of the papillary muscles of the mitral valve. So basically, this papillary muscle, they control the mitral valve. And in this case, if there is rupture of the muscles, it's the mitral valve won't function efficiently. So when there's rupture of the papillary muscle, there is inadequacy of the mitral valve and regurgitation happens. So this happens 2 to 15 days following a myocardial infarction, typically the inferior MI. So when you auscultate, you'll hear early to mid diastolic or a pansystolic murmur. Again, you would do an echocardiogram. For arrhythmia or aneurysm, as I mentioned earlier, for arrhythmia, the patient could present with ventricular tachycardia or even ventricular fibrillation. And in this case, ventricular fibrillation is very dangerous because the cause of death following a myocardial infarction is due to ventricular fibrillation. So for left ventricular aneurysm, as I mentioned before, due to the ischemic damage, it weakens the heart muscles, the myocardium, and this will result in a thin muscular layer finally forming an aneurysm. And this happens 4 to 6 weeks post-MI. If you were to do a chest x-ray, you would see an enlarged heart with a bulge, usually on the left heart border. If you were to do an ECG, there is persistent ST elevation plus left ventricular failure. And if you were to do an echocardiogram, you would notice paradoxical movement of ventricular wall. It's very important to remember this complication because in the case where there's MCQs, they would write the story like this. For example, a lady who suffered a myocardial infarction maybe about 4 to 6 weeks ago presents with acute limb ischemia. So there is the limb, okay, let's say acute limb ischemia of the left arm. So it's pale, pulseless, so on and so forth. So it's actually due to this, the complications of left ventricular aneurysm. What happens is thrombus may actually form within the aneurysm, and this can increase the risk of stroke. And sometimes the patient may even come with stroke, but sometimes they may come with acute limb ischemia depending on where the thrombus gets occluded. Okay, so for Dressler syndrome and pericarditis, as I mentioned earlier, they actually have the same presentation, but you need to see the duration following a myocardial infarction. So when a patient comes in with pericarditis or Dressler syndrome, they would have pleuritic chest pain. Basically, chest pain that is worse when they breathe in, but the moment they lean forward, it's relieved. In the case of Dressler syndrome, they may even have fever. So the difference in duration for acute pericarditis, it's 48 hours after a myocardial infarction. For Dressler syndrome, it's 2 to 6 weeks following a myocardial infarction. And the difference here is that Dressler syndrome is an autoimmune reaction. So if you were to do an ECG, it's the same, okay, for both. There is widespread saddle-shaped ST elevation with upward concavity, this part here. Basically, the ST segment is elevated, okay? Can you see this? It's elevated. And then there's upward concavity, this one. And sometimes they may even have PR depression over here, this. Alright, so let's move on to pulmonary embolism. So for pulmonary embolism, the patient may present with breathlessness, chest pain, obviously, and sometimes even cough pain or swelling. And this is indicative of DVT, deep vein thrombosis. The most common cause would be a deep vein thrombosis. It's a pulmonary embolism and deep vein thrombosis are part of venous thromboembolism. And what are the risk factors? Most common cause would be immobilization. Basically, if they have just completed surgery or they went on a flight that's really long, and usually when they say when you're flying somewhere, it's best to get up in between, when it's safe to get up, of course, and walk around for a bit because it's really dangerous to remain idle for so long because this can happen, pulmonary embolism or deep vein thrombosis. Basically, you want to prevent venous thromboembolism. Apart from that, smoking, cancer, and also patients who consume estrogen-containing contraceptive pills. So it's important to remember the risk factors because they can even ask during your long case bedsides. Okay, so the investigations. You need to check the Wells score. If it's more than 4, it's likely a pulmonary embolism. And if you were to do a D-dimer test, it would be positive. And the best approach would be the CT pulmonary angiogram. If, let's say, the patient can't do a CT pulmonary angiogram, they can't do a D-dimer's test, then you can opt for ventilation perfusion scan. But that's usually kept for last. And on the ECG, you would see S1, Q3, T3. Take note of this and remember this. Obviously, you don't do an ECG first in this case, unless you suspect, that this patient might have an MI. But if you were to do an ECG, this is specific for pulmonary embolism. So there is S wave in lead 1, Q wave in lead 3, inverted T wave in lead 3. So sometimes they would like to ask this maybe during bedside teaching or a long case. Okay, so treatment, if it is massive, it depends on the size. If it's massive, then you would opt for fibrinolysis or a pulmonary embolectomy. Basically, you just cut open a patient and, remove their, remove whatever is occluding. And then if it's a small PE, the first line would be apixaban or rivaroxaban. And if that's not available, you can opt for a low molecular weight heparin for 5 days. And if it's recurrent, then you can opt for vena cava filters. So let me go through a little bit about Wells score. You don't need to remember, at least in my case, you don't actually need to remember the Wells score. But it's good to know. You basically just need to know the score if it's more than 4 or less than or equal to 4. So these are some of the components, not some, it is the components of Wells score. So after you've calculated the Wells score, if it's more than 4, you need to do an immediate CT pulmonary angiogram. You basically want to see which part, where is it actually being occluded in the lungs. And if it's less than or equal to 4, you do a D-dimers test. And if the D-dimers test is positive, then you do an immediate CT pulmonary angiogram. If it's not positive, then it's less likely a pulmonary embolism. All right, so let's move on to cardiac tamponade. So cardiac tamponade, by definition, is the accumulation of pericardial fluid under pressure. And it's very important to remember this Beck's triad. If you can't really remember anything about cardiac tamponade, remember Beck's triad. It's associated with cardiac tamponade. So sometimes they may say the patient comes in with hypotension. Upon auscultation, you can't hear the heart sound, but the neck veins are distended or has high JVP. So if there's hypotension, muffled heart sounds, high JVP, it's indicative of cardiac tamponade. These are the Beck's triad. So other clinical features: dyspnea, pulses, paradoxes, tachycardia. And cardiac tamponade actually can be a complication of myocardial infarction. So what happens is, after an event of myocardial infarction, patient develops acute pericarditis, pericardial effusion happens, and cardiac tamponade. But the most important cause is not actually myocardial infarction. Usually it's due to trauma. That's when they present with a cardiac tamponade. So the investigations you would do, like I said, in the case of a cardiovascular case, these three comes together. You want to do a chest x-ray, you want to do an ECG, and an echocardiogram. So if you were to do a chest x-ray, you would observe an enlarged globular heart like this. I mean, it's very noticeably enlarged, or the water bottle sign, because it looks like a water bottle actually. And if you were to do an ECG, you would observe electrical alternance, and the best diagnostic would be echocardiogram. So the treatment, the first step in this case, you would need to oxygenate the patient, oxygenation and ventilation, secure their airways first. And if the patient is hypovolemic, then you would give them IV fluids. But the definitive treatment is urgent pericardiocentesis. So of course, in this case, if it's a cardiac tamponade, you don't just delay the patient, but this is important because in MCQs, if they ask what's the first step, or the patient presents as a hypovolemic, so on and so forth, or they ask you what is the definitive treatment, then you go about this. So if you were to do a chest x-ray, and it shows an enlarged globular heart, you think of either two things, either pericardial effusion or cardiac tamponade. Alright, so if you've reached this part of the video, thank you so much for watching. Do hit the subscribe button and press the notification bell so you don't miss out on any new videos. And I post videos weekly, and I will see you in the next one. Stay tuned.